Dear colleagues, ladies and gentlemen, welcome to the View from the Thoraxcenter for Radcliffe Cardiology. My name is Nicolas van Mieghem, and as always, I do this View from the Thoraxcenter together with my good friend and colleague Jos Daemen. Today, we're gonna preview the ACC, the late-breaking trials from the upcoming ACC meeting. And Jos, there's a lot to talk about.
A lot of interesting trials to be expected at the upcoming ACC meeting. We will present the highlights, at least trials that we think are of interest for the interventional cardiology community. And 12 to 13 trials will be briefly discussed within the next 20 to 30 minutes. So the first trial that we wanted to highlight is the ultimate DAPT and IVUS-ACS trial. So this is a prospective multi-center randomized controlled trial designed to determine, one, whether a IVUS-guided revascularization strategy is better as compared to angio-guided implantation in patients with acute coronary syndrome. And second, to assess whether Ticagrelor alone versus Ticagrelor plus aspirin reduces the risk of clinically relevant bleeding without increased risk of MACE at 1 to 12 months after index PCI in patients presenting with acute coronary syndrome. So this is a Chinese trial enrolling 3,500 ACS patients. That will initially, per procedure or pre-procedure, will be randomized to either IVUS or angio-guided PCI, and then if they are event-free at 1 month in a design that you're familiar with, they will be randomized to either a Ticagrelor monotherapy or a treatment with DAPT up to 1 year post-randomization. So Xiaolang Chen will present the IVUS-ACS results. These to me are important data since as of today there are no dedicated large randomized controlled trials showing the superiority of IVUS-guided PCI as compared to angio-guided PCI.
In ACS.
In ACS in particular. I'm curious to see in this trial what the distribution of ACS cases will be. I don't expect that the vast majority of patients will present with STEMI. If there are a lot of patients with non-STEMI or unstable angina, that takes away a little bit of the novelty of the trial, but we'll see. Second, Greg Stone will present the second part of the randomization, namely the ultimate DAPT trial, which is the randomization to Ticagrelor monotherapy versus DAPT. So my guess in this Chinese trial is low event rates. I assume superiority of IVUS. I assume as well superiority of bleeding in terms of the Ticagrelor monotherapy arm, and non-inferiority with respect to the ischemic endpoint of Tica mono versus DAPT. Moreover, it's interesting to mention that this trial follows the protocol of the COMPARE-STEMI-1 trial that we're currently running in Rotterdam, and I assume outcomes very much in line with the previous TIPA, STOP-DAPT-2 and Twilight trials. So from that perspective, a large Asian trial that should cause some discussion during the course of the meeting.
Yeah, but as you say, a lot of trials that have already looked into abbreviated DAPT therapies. I would have been more interested in just dropping aspirin after the PCI.
From on the start, yes, I agree. You preload them and then you stop. Because now you get this sort of natural selection at 1 month, in which obviously, I mean, if somebody had a stent thrombosis at 3 weeks, you don't want to stop.
That's fine. Period, yeah.
But I mean, that takes away, I mean, in routine practice, you will not call back the patients at 1 month and then see. You can, but I think a more consistent approach would be as you described.
But again, Greg Stone will be very active because not only will he discuss DAPT, but he also will present the RELIEF HF randomized control trial. And this is a highly anticipated trial with a lot at stake because it evaluates, it's basically the second big trial that evaluates the concept of interatrial shunting for patients with heart failure. And both heart failure with reduced ejection fraction and with preserved ejection fraction is allowed for this study as long as the patients are quite symptomatic. So they need to be at least New York Heart Class 2, and if they are New York Heart Class 2, they also need to have elevated NT-proBNP or a history of heart failure hospitalization. So we're talking about a real heart failure population. What is of interest is obviously this trial has been enrolling patients for quite some time, so you want to make sure that these patients are on guideline-directed medical therapy, but that is a dynamic identity, right? It's changing, this guideline-directed medical therapy. So how will they interpret that piece of the trial? But I think obviously the most important question is, does interatrial shunting work? We already have one other big randomized controlled study, that is the reduced LAP-HF trial with the Corvia shunting system. That was a negative trial. And yes, they were looking into subgroup analyses and they did find some signals of benefit in more selected patients. But at the end of the day, the patients from RELIEF-HF are still quite general. It's not a very niche group of patients. So yeah, we'll see what the end result will be. The primary outcome, efficacy outcome, is a hierarchical composite, as is typical for these kind of trials. That includes death, heart transplant or LVAD, implant, heart failure hospitalization, worsening of heart failure, and then also a change in KCCQ. Very difficult to predict the outcome of this trial, but my gut feeling tells me that it's going to be tough to see a significant benefit overall, but probably there will be some subgroups that seem to respond.
That is what I anticipate. I mean, this is a very broad endpoint that comprises virtually everything that you can imagine in terms of endpoints in these patients. It's a second version of the device, right? I mean, the first generation had problems with restenosis, so to say, with a decrease in the shunt fraction. Now with the second generation of the device that is being tested in this trial, that has been supposed to be resolved. So I'm curious, and I look forward to the results.
But it will definitely generate also a lot of discussion in terms of patient selection, but also in terms of the device that is being used and the kind of shunt that you want to create, and so on. But okay, let's move on to ORBITA-COSMIC.
Yeah, more on devices. In this case, another trial on the Reducer device. So as you recall, Reducer is the hourglass-shaped balloon-expandable mesh that is implanted in the coronary sinus, actually to improve angina in patients who don't have a clear epicardial target for revascularization and proven ischemia. So you recall the COSIRA trial that Stefan Verheer published in the New England Journal of Medicine almost 10 years ago, in which in 105 patients, the investigators demonstrated a clear and significant improvement in quality of life and anginal symptoms in these types of patients versus sham up to, I think, 6 months. In this case, the investigators from the ORBITA group, so Rachel Lamé and colleagues from London, actually questioned the mode of action of this device. And from that perspective, I agree. I mean, there's still a lot of unknowns in determining how this device actually works. In that perspective, they now designed, again, typically for this group, a very small but mechanistic trial in which they try to prove that implantation of the Reducer improves ischemia as defined by myocardial perfusion MRI at 6 months versus a control arm in this 50 patients. So all in all, a trial that is welcome given the persistent questions regarding the actual mechanisms of action of the device. However, with 50 patients, MR endpoint, I'm not really sure what to expect, honestly.
I agree, and it's small numbers, also a niche indication, so not very attractive commercially proposition, I think. So, but let's see how it works. So let's
upscale a little bit.
Yes, and go back to the patients with myocardial infarctions. There are two interesting pharma trials. One is the EMPACT-MI trial that evaluates empagliflozin, so an SGLT2 inhibitor, in patients specifically within 2 weeks after a STEMI or a non-ST elevation myocardial infarction. Patients need to have some signs of congestion, and their ejection fraction needs to be depressed. So we are definitely looking into a high-risk patient population after a myocardial infarction, and then patients will be randomized to empagliflozin or control. The primary endpoint is a typical one, composite of time to first heart failure hospitalization or all-cause mortality up to 2 years. I'm a big believer in SGLT2 inhibitors. I think rightfully so they are part of the current heart failure guidelines. my bet is it's going to be a positive trial.
I totally agree. And I mean, if you use this drug in clinical practice, I mean, this is, it's unbelievable. I mean, patients come back and they just feel better. And that is something we've not seen that much with a lot of the things we did in the past.
And limited side effects. The only thing is that, you know, the mode of action, so how does it become so effective? That is a little bit
maybe
strange.
another target for the ORBITA group.
Yeah, but there is another trial that discusses a different topic in heart failure treatment after myocardial infarction, and that is the REDUCE-AMI trial. And this is a very important study because according to guidelines after an MI, we prescribe beta-blocking agents, but that hasn't been studied very well in patients who have a preserved ejection fraction after a myocardial infarction. And I think this is where REDUCE-AMI comes into play. It's a very interesting registry-based, randomized, parallel, open-label, multi-center trial.
A mouthful.
Yes, performed in the Scandinavian countries, Sweden, Estonia, but also in New Zealand. And 5,000 patients with an acute MI who have undergone a coronary angiogram and with a proven ejection fraction above 50% will be randomized to long-term treatment with beta blocker or not. And I think this is very important because also patients who were on a beta blocker upfront, so before they entered the study, they will be tapered off and will be put off a beta blocker. So I think this is very important. So they have thought very well about the study design, and then patients in the treatment arm will receive either metoprolol or bisoprolol at doses of at least 100 milligrams and 5 milligrams respectively. I think this is going to be a very interesting study. I'm not sure whether it's going to be positive because in this day and age, the treatment of myocardial infarction, the revascularization strategy, but also the impact of high-dose statins and all the other treatments that we have may make beta blockers redundant. Let's see what the results are.
Yeah, I'm also not so sure. I mean, the benefit of beta blockers in MI settings has been mainly based on the prevention of arrhythmias in the early phase, and in which you can give IV beta blockage, etc. For the long term, specifically in patients with preserved EF, I'm not so sure. Also given the fact that 100 milligrams of metoprolol in somebody with a completely preserved LV function, small MI, I'm also curious to see how many patients will tolerate it and will stop it before the primary endpoint was reached. So
my gut feeling, 1 in 5 will stop it.
I think more.
Okay, so
let's see.
That's going to be an interesting one. Okay, let's switch to the structural heart space. There are several interesting randomized controlled trials that will be presented. The first one is the SMART trial. This is a Medtronic-sponsored randomized controlled trial comparing balloon-expandable with SAPIEN with the self-expanding evolute valve in patients with small anatomies. Howard Herman is going to present for the first time this data, and obviously we will expect the majority of patients being women because smaller anatomies predominantly will be found in women, and 716 patients from 92 sites will be randomized to either the balloon-expandable or the self-expanding system. And the primary endpoint is a composite of mortality, disabling stroke, or heart failure rehospitalization at 12 months. But there is also another co-primary endpoint that focuses on the bioprosthetic valve performance. And that includes also the presence of a mean gradient above 20 millimeters of mercury or the occurrence of more than mild paravalvular leak. You know, I would predict that for the first endpoint, the clinical efficacy, there won't be a difference between the two treatment strategies, and probably based on the current existing proposition, you might expect that evolute should dominate in terms of bioprosthetic valve performance, but you never know. You never know.
Well, why this endpoint bioprosthetic valve dysfunction? I mean, this comprises several parameters. We know more than mild AR is rare. Severe patient prosthesis match is also in these type of patients likely relatively low. So why not just pick a gradient?
Well, I think that could have been the case
because that's what I assume they will find, that there is a different gradient in favor of the self-expanding system, but whether that will translate in a difference in bioprosthetic valve dysfunction.
Yeah, because this is obviously an endpoint that is proposed by the Valve Academic Research Consortium, right? So I think it is...
It's supposed to be relevant. I think that is a good argument, but... let's see.
Yeah. Next one is the DEDICATE DZHK6 trial, and this is a German trial that is coming from Hamburg University. An interesting one because obviously it's not industry sponsored, and this trial is looking to compare TAVI versus surgery in patients at low to intermediate operative risk. Patients are above 65 years old, they are only at low or intermediate, so high risk is excluded, but also patients with coronary artery disease, with bicuspid aortic stenosis are excluded from the study. So that tells me that the mean age of the patients will be relatively higher because you exclude all the bicuspids. And what I think is a limitation, a major limitation of the study, is that it allows transfemoral, but also alternative access in the TAVR group. And, you know, a patient with no good femoral access in terms of TAVI is a different animal. And so this will add a lot of noise to the study results. So if I would have designed the study, I would have excluded the patients with non-transfemoral access. But we'll see. This trial should become a non-inferiority study, and I would expect that TAVI would be non-inferior to surgery at 1 year at their endpoint, at 1 and at 5 years.
Well, I agree, but to your point with respect to the alternative access, I mean, a transaxillary or a direct epical or whatever kind of approach is higher risk for TAVR, but these patients have severe vascular disease and are also a higher risk for surgery. So at the end, I don't think that will drive a potential difference.
It shouldn't, but if you would have 100 patients with an alternative access, we know it from the partner trials that, you know, alternative access comes with a price. Also, with the high risk and intermediate risk Evolute core valve studies, it's a different animal. So that's a little bit of a pity, but then again, we would anticipate a non-inferiority. So let's go to another trial that we wanted to highlight. This is the PERFORM-TAVR trial. This is a randomized study evaluating TAVI in patients who are frail, and then see how we can improve outcome after the TAVI. Patients will be randomized after TAVI to a treatment that consists of exercise testing under the control of a physiotherapist, but also there will be some protein-rich oral nutritional supplement on top of that. And so 100 patients will get the exercise treatment in combination with this supplement, this nutritional supplement. The control arm won't get the physiotherapy and will not get this supplement. We'll see. I think it makes sense to focus a little bit more on the frail patients after their treatment. We already know that frail patients don't do very well after surgery, but also their outcomes and their survival and their changes in quality of life is limited after TAVI. So if we could modify that by improving physical activity and also improving their nutritional state, that I think makes a lot of sense.
Yeah, conceptually, absolutely.
Yeah. Then PREVENT.
Yeah, so moving a little bit to the coronary space, a lot of trials to be expected. One trial that we would like to highlight is PREVENT. So PREVENT is a trial designed to assess whether preventive PCI, initially designed with bioresorbable scaffolds, but later on added with regular Zynes and everolimus-eluting stents, for functionally insignificant vulnerable lesions would result in a significant reduction in target vessel failure at 2 years versus optimal medical therapy. So Sanjong Ajay Park will present this trial, 1,600 patients that will be randomized to either stenting or optimal medical therapy. If I'm correct, both patients with chronic coronary syndrome as well as ACS can be enrolled. It's again a trial from the eastern part of the world, 15 hospitals, 4 countries, Korea, Japan, Taiwan, and New Zealand. What type of lesions are we looking for? Because this is preventive PCI, so to say, but preventive defined based on physiologically non-significant lesions. So you need to have a lesion with at least 50% in angiographic diameter stenosis, a FFR that is negative, so above 0.8, and then 2 or more of the following. Either plaque burden above 70% based on IVUS, MLA smaller than 4, or signs of TICVA based on OCT or VH-IVUS, or a LCBI score of above 315. Which parameter you pick is depending at the operator's discretion and depending on whether the operator wants to use either IVUS, OCT, or a near-infrared spectroscopy. So that is left to the institution, but there needs to be a sign of vulnerability with criteria that have been validated in previous imaging trials. So to me, a very interesting concept. It's a trial first of its kind. However, my concern is a little bit with respect to the sample size. So assume a lot of patients with chronic coronary syndrome. We know that these patients, if the FFR is negative, have very low event rates. But, of course, not selected for vulnerability criteria. So the investigators anticipate a relative risk reduction of 30%. I'm not sure they will make it. I also don't know what percentage of patients got the BVS, because that may also drive part of the event rates. So definitely something to look out for in my perspective.
Oh yeah, for sure. This trial has been long overdue.
Yeah.
I think the concept was already there 15 years ago. I remember when I arrived in the Thoraxcenter, we were also doing a study with Professor Serais in focusing on the vulnerable plaques. And I think this is next level, you know. This is, I think this is a bold trial, and it goes beyond angina. But conceptually, it makes a lot of sense. And,
and it also puts a little bit in perspective how we look into lesions. Because this binary type of medicine, whether you pick stable or unstable patients, do a physiological assessment, pick a binary figure of 0.8 and decide on whether to stent or not, without looking on whether this lesion is focal or diffuse, and without looking if there is a TICVA or a ring of calcium, to me doesn't make any sense in this day and age.
Okay, full revasc.
Yeah, full revasc. So talking about FFR, full revasc is now the third randomized controlled trial designed to assess whether a FFR-guided complete revasc is better as compared to culprit-only PCI in patients with STEMI. Again, a trial 1,500 patients in this case with either STEMI or high-risk non-STEMI from Scandinavia, Australia, and New Zealand. As far as I understood, following also the trial we just discussed, it's a registry-based trial. It follows the negative Ffr-MI and the positive frame AMI trial. My guess, no superiority in the Ffr based on FFR and STEMI. Higher rates of event as compared to ACS. Bystander disease is different, typically more aggressive. And again, I think to me the way forward is in the intravascular imaging field in these, let's say, non-culprit lesions in patients with ACS, and not just in the binary figure of FFR.
Totally agree. We should move beyond that concept. You cannot do these trials without invasive imaging, in my opinion.
Yep.
All right, that brings us to the danger shock trial. Talking about a trial that has been long overdue. This trial,
long anticipated.
Yes, this trial started already in 2012, so 12 years ago, and it was a very relevant trial back then. It is still very relevant, although with the ECLS AMI shock trial, we got a little bit anxious with this group of patients. Well, we're talking about patients with STEMI within 36 hours of STEMI admission. And patients are in cardiogenic shock. The cardiogenic shock should not last beyond 24 hours. And a proven ejection fraction less than 45%. 360 patients will be randomized to either Impella MCS, mechanical circulatory support, or conventional support that may include balloon pumping. The primary endpoint is all-cause death at 6 months. And this is a very important trial because we all are using Impella mechanical circulatory support for this indication. The question will be how many patients had an out-of-hospital cardiac arrest, because we've learned from the past that is a driver for the outcome, and it makes it much more difficult to come up with some positive signal in those particular patients. And what about the signal of harm? Does the use of Impella come with more bleeding and access site complications in this particular vulnerable patient population? So this is definitely not a home run trial from the get-go. This is going to be a highly anticipated trial.
Yeah. To me, what will be the most intriguing item to look for in the presentation is the time to starting of the circulatory support. If you wait 30 hours, if you wait 6 hours, I guess that the window of opportunity is lost. I mean, in patients in whom the device or the mechanical circulatory support is started early on, so preferably within 90 minutes, you may expect something. But in those in whom you started the pump after 24 hours.
But that's exclusion, huh? So those patients are
so
in
up
principle
to
excluded. Yeah.
Yeah, so 20 hours could go in.
But but I agree with you. So the timing also will drive outcome in this particular group of patients. Absolutely. But we come to the end of our presentation, and of course there is again renal denervation. So what's happening now, Joost?
Yeah. So again, an important trial to be presented at this ACC's meeting. So the Target BP randomized control trial. David Kandzari will present the primary 3-month outcome of this trial, which is a sham-controlled randomized controlled trial testing the effect of alcohol-mediated renal denervation on blood pressure in the presence of antihypertensive medication. So this is the trial of Ablative Solutions, which is next to Medtronic and Recur, now the third significant competitor in the RDN field. The trial has a familiar design, basically enrolling 300 patients with uncontrolled hypertension on 2 to 5 antihypertensive meds, office BP between 150 and 180, mean diastolic blood pressure above 90, which will be randomized 1-to-1 to either alcohol ablation or sham, with the primary endpoint being the change in mean 24-hour ABPM from baseline to 3 months. The company already announced to be able to release positive findings, but at ACC, as said, David Kandzari will present the full analysis. To me, again, interesting, specifically given the type of the procedure. This is a device that is extremely simple. It's just a catheter that you advance through a 6 or 7 French guiding catheter. There's no need for a generator, no electricity. It's just a simple catheter with 3 needles in which you inject up to 0.6 mils of ethanol in each renal artery. It's a one-size-fits-all device. It's simple, it's extremely fast. We were part of the trial, so we did a series of cases, and mechanistically, the trial has to prove the concept, but from a practical perspective, I think this could be a significant competitor to the field.
And this is the next in a series of sham-controlled, randomized controlled trials. So I would definitely look forward to first, obviously, the results, but you already hinted to the positive signals that were already released. But then the reaction of the hypertension community. When will they start to embrace this kind of treatment option for their patients, right?
Yep. Yeah, that's the ongoing discussion. There are now recommendations in national consensus papers. There's European consensus paper. There are new guidelines released by the ESC and ESH. Now another series of guidelines is to be released, so I think it's time for embracing the technology, which is now being picked up in a lot of countries, also with reimbursement discussions going in the right direction.
All right, with that we come to the end of this preview of the ACC 2024. A lot to look forward to. We'll keep you posted on the outcomes, so stay tuned for the wrap-up later on. Thank you very much.
Thank you for watching. Bye-bye.